Good afternoon, everybody. Though I am grateful that a lot of what I am going to say has also been covered by my senior Dr. Ram Narayan, and luckily I have certain aspects where he left was the last portion regarding managing the change part of it. So I would like to dwell upon a little bit on that more carefully, and we will go through some parts of it which you have already heard. And in fact, what is disruption defined is an innovation that creates a new market and a new value network. That you just heard what Dr. Narayan has said. I would like to go further and state that it is organic and incremental changes are not disruptions. Anything which happens over a period of time cannot be called as disruption. Second is that disruptions generally come from outside and not from within. Third is disruption absorbs losses but soon overpowers. Many a times what has happened, disruptions have come to the market, people have tried it and then it has failed. But after a period of time, people have, the disruption has overpowered the established market. Lastly, disruption innovations may not necessarily be economic substitutes. Sometimes disruption always does not mean that a disruption has taken place because it is cheaper. You know, the example is that when we had the watches which were made of, which had hands, the normal kante wala ghadi, they were, you know, at one time a lot of these liquid LCD digital clocks had come and they were available as cheap as 10 rupees or 5 rupees also, available in kgs. But those, and everybody thought that a time has come that the Swiss watch companies and all these which are there, such cheaper watches are there, they are also showing time. Why should people buy them? But unfortunately it didn't happen. So it is not necessary that only cheaper substitutes are worked. Disruption can be costly also. And finally, classical in the medical world, example is the classical test tube method has been replaced by the handheld glucose devices. Or for example, the conventional, the ribbon kind of ECG has been now overtaken by an electronic data recorder, which not only records, it transmits and gives a digital platform and can send it to the mobile of the concerned physician, and that too with an artificial intelligence to give us a requisite amount of alarm. And lastly, the retail primary clinics with nurse practitioners. This is coming in the West where they are finding physicians are very costly. So the primary clinic chain is coming up gradually. In India also some of the investors have tried to start primary clinic attached with home care. I will talk about it a little later. And it is in an incipient stage, but and they are bearing losses, like I said, at this point of time. But maybe that if that disruption succeeds, it's going to take away a lot of bed occupancy from a lot of hospitals and a lot of work which people usually visit there. So this is what it is. Lastly, use of internet, mobile, like Sir had also just mentioned, that actually has given a remote access and is also a form of disruption where people were dependent in a small town to the local doctor available. But now with accessibility, they can get a second opinion right without moving there. So they know how to and when to question. So it's a disruption to the local market as well. What could be the types of disruption? I mean, the same thing, but a little differently presented. If you see, technological innovation, like Sir has said, process innovation and infrastructure innovation. And what are the impacts? Impacts are, you know, technological innovation lead to investment decisions. You have to either disinvest, lower the invest or higher the investment. Whatever it is, it has got an impact on the investment. More the newer technology is coming from earlier from open surgeries to keyhole surgeries to lap surgeries to endoscopic surgeries and now to robotic surgeries. In my organization, there is a talk going on, why can't we have robots in 2 of the hospitals? I said, why do you want so many robots? Because we can do without it. They said, no, other 2 hospitals are having, we have to be seen as having more advanced technology than the others. So the question is, that is an investment decision. Finally, the common response, what the health system actually responds, this is my way of looking at it. First is conservative approach. The service, the system actually what it does, it blocks the disruption by labeling that as unsafe and untested. The commonest phenomena, no, reject it. It's not correct. How can without a doctor you can have an opinion? You know, in good old days, at 5 years back when cyber security laws were not effective, they said telemedicine is illegal. You cannot do. You cannot even give advice. Medical council said that we will put you to jail if you write a prescription accordingly, and opinions cannot be given. Now the entire country is using teleradiology as giving opinion. They might give 10 disclaimers, but the fact remains that the opinion is being given on the image which is there. So immediately first was unsafe and untested. That has been taken care. The second is a second mover strategy. The smarter people, then they say, they are sitting on the fencing and seeing that if the technology is good, why not to adopt it as a second mover, modify it, invest some money and take it to the next level. And the last one is first mover agency, gaining reputation as innovator and differentiator. There are many examples in this country. If you see 1980, the hospital industry in India can be divided into pre-80 and post-80 era. It is only the post-80 era when when it was given the nomenclature of industry came in and Industrial Dispute Acts came in, the financial regulations changed, hospital came under infrastructure, you start getting long-term loans at a very cheap, with lot of taxation relaxation and much cheaper interest rates. And that is how people started looking at hospital as an investment destination, and it grew. So the question is, during that period also, if you see, some of the first movers were there who started technologically advanced, very high class hospitals, suddenly they brought in. Everybody said they are too costly, people will not buy it. But today if you see, many of the chains don't have enough beds to fill up. So that is where it has come to. And they have taken away the business from the routine, in routine parlance they call it mom and pop shops, but routine nursing home kind of practice, the doctor owned practice, the 10-bedded ones, many of them have been invaded and thrown out of the market in many cities. Coming to the next slide is enablers. What are the enablers of disruption? You know, medical knowledge is evolving. As the continuously evolving, we are continuously getting into algorithms, protocol, regulations. So protocol based, now you know, and with the help of protocol you can use, if what a doctor could have done, you give a protocol, a paramedic will do, and give a protocol, a nurse will do. Given protocols are given at the auxiliary nurse midwife also. She also knows the 5 cleans, she also knows when to see the obstructed labor. What? This is all protocols. Once upon a time, this was only to be done by a qualified doctor. So the first and foremost is the evolution itself has taken it to the next height. The second is demand on increasing need of handling complex conditions. What has happened once these lower things have become protocol based, the higher things, the demand for higher things came in. So what the demand for higher things came in, now we want, we want people only who know only to do surgery of pancreas, or there is a surgeon who only knows surgery of adrenal. So it is over fragmented, super specialized, and complexity of care. That is what is more demand. So that also demands a lot of disruptive innovations to come in. So the routine kind of work is no longer getting its due. Third is moving department structures to service lines. Now earlier we have department of medicine, surgery, obs, gynae, or surgical division or medical division. Now you have a department of, in the eye you have a department of eyelid or an iris or retina or the eye, probably whatever are the organelles available within the eye. All of them are also super specialized. So there is a service line. There is an orthopedic surgeon who says I only do spine. So therefore there is a service line in my hospital called Department of Spinal Surgery. There is a service line in my hospital which only called Department of Hand Surgery. So from human body it has come to fragmented, disseminated, different kind of super specialized practices. So what happens? These departmental structures have developed into products and services. Lastly, decreasing focus on revenue generated from service. Earlier hospital means nursing home. You nurse a person, you heal him, you get him well. Now it is nothing like that. The nursing and bed charges are secondary. The charges are more towards the technology which is used on the person, the equipment which is used on the person, or the implants which are used on the person. So the revenue generation is from products and not from the service side of it. I will quickly give some examples in the health sector. Shift of focus from acute care hospital to outpatient facilities to home care. Few years back, I am still saying, government says, or all the data says, we need, so many lakhs bed more in India. In my opinion, very soon a time will come that the beds will be surplus. because we are moving from short stay surgeries, we are moving into daycare surgeries, nuclear families are there, people are not ready to get admitted. The outdoor work will be increasing, and the top surgeons would also like to reduce and send the patients on discharge as early as possible. So what has happened is people who would be in potential cases of probably visiting a hospital, now they will visit primary care and they will be handed over to a home care service. Many of the post-operative cases in our hospitals in Bangalore, we have got a total tie-up with another home care agency. The patient is discharged and we hand it over to them, and we take a tie-up and they bring and they do the needful. Whereas that many hospital bed days probably they would have occupied either in a nursing home or in our hospital. So from hospital to primary care to home care, that is one of the examples of disruption. If that storm of home care and primary care takes over, it is going to carve a lot of dent on the demand on the hospital beds. Second is expanded physician relationship network. Third is coordinate with other ambulatory. This is what it is, the part of this shift of focus. What is the impact? Access to more data on patients, help managing population health. Tomorrow if you do a lot of primary care, lot of primary physician involvement, you can also start getting into preventive mode of non-communicable diseases. You can get into algorithms that the diabetics has to be trained to stop smoking so that he lives better in his vascular, for his vascular tissues, and so on and so forth. Assist in transportation, this is what they do. Large number of plant footfalls to nearby hospitals will get eroded, prompting them to rethink on their business model. So if primary and home care starts working as a disruption, tomorrow it is going to be a tough time for the neighborhood hospitals. The next one is remote ICU. In Delhi they have started a group of critical care people. They take over 2-3 intensive care units in the nearby or 5 to 10 kilometer vicinity. They have a base command station, and they have a critical care team at the base station. They have regular doctors or MOs who are doing there. Most of the manipulations in the drug, dosages, oxygenation, ventilation is commanded from a central team, and they go and take care of these patients. Now what is happening, I mean, I don't want to name, there are few very big hospitals whose ICUs are over occupied. They have hired some nursing homes in the nearby, calling them as their remote ICUs. Now this is again an innovation, and people know that you are under the same basic care, only thing is you are 10 kilometers away. So this is something coming up. What is the impact? Impact is, sorry. Can you take it back please? थोड़ा पीछे ले जाना, थोड़ा पीछे करना. That's it. Bus. So what is the impact of the remote ICU is, less stress on the patient beds in the main unit, cost of care comes down, and market erosion for the standalone units. Now people who had standalone units, who created ICU as an investment, very high cost investment, they are likely to get a dent, because if one particular group starts taking 5, 10, 7, 10 ICU units, it's going to be a problem. It's happening in Delhi, it's already started. Challenges to innovative business models in India. One is that we have got fragmented care. Single organ specific facilities can have cost savings and efficiencies, but have supplemented with health IT system coordination by patient-centered medical system, home service, all of them is required. We don't have that much of integration. We don't have patient health records available on cloud. We cannot access to them. Something like there is a Cisco model where they say that the patients, everything is available in the hospital. All he has to come with just a chip. And once he comes there, his past history, present history, everything is available. Who treated him? Where all did he go? We don't have such thing. We have got a fragmented care. Second is lack of retail market. Consumers are often now attached to a third party payment. We have people who are buying out of pocket, but in major metros, and 30% of population is now covered with some scheme or the other. The poor is covered under BPL, RSBY, Arogya Shri, Rajiv Gandhi Yojana, Chiranjeevi Yojana, and so on and so forth. So there is always a third party payment, government servant under CGHS, ECHS, and insurance, and so on and so forth. So what has happened is that retail is not there. So once it is third party payment, you are framed and pre-decided to choose a destination. You cannot go to an innovator. So that is the second part. Third is regulatory barriers. Example is restriction of physician to own hospitals. It's not one hospital. In US, there has been a restriction that the doctors cannot own their own hospital, so that they will have conflict of interest. India, that law is not there. But that is possible. It may come in some shape tomorrow. And the fourth is shift of focus on improved efficiency, leaving complex areas to a limited few. What is happening is reducing reimbursements. Every time you have the third party payment, you will find that the reimbursement is coming to the same. Government is not increasing CGHS rate or ECHS rate. Rather, they have done more restrictions in causing what sir was saying in the morning. That if you reduce the cost of implants, it doesn't mean that more people will get it. But that is how it is. So the innovations are restricted. Why good organizations go bad in disruptive times? Now this is where I think a little different from what my previous speaker has spoken. You see, what happens is when you have disruptive times, people try to cope up with the change in various manners. In my opinion, the first one is that strategic frames, we call it blinders. The assumption is that how the managers view their business. Blinders means that you look the other way around. Oh, this is not the way we do it. We have our own ways of doing it. So that is one thing. Rajput Dharma mein ye nahi likha hua hai, something like that. The second is processes and routines, the way the organizers look at it. Third is relationship. They liquid to shackles. If I do it, then I will have spoiled relationship with 3 other business partners. So I would rather restrict myself to that. And the fourth is values. Like I said, like sir had said, that core values and culture, they sometimes become a barrier to look at the things differently. So that is how analyzing the responses to change. How do you people respond to change? One of them is there is a proposed change. So when there is a proposed change, there are a lot of attitudes which come into the play, and it is attitude of not only the leaders but of the masses. We don't do this way. We don't look at it like this. We will look at it differently. So there are psychological factors, fear, suspicion, risk-taking profile of the person. Should it be a profitable thing and all? The second is the personal factors, the economic factors, whether it is going to be worthwhile financially or not. There is always a fear of unknown. The third is social factors. Will I be spoiling my relationship with people? And the fourth is, then they start evaluating. After evaluating, there can be anything. First is rejection, where he says, no, I will continue to do the same way what I was doing. And that is how many of the old healthcare hospitals and healthcare institutions doing extremely well. I know there are many failure stories in private sector also, because they did not try to change with time. So they rejected all kinds of ideas. They said, we'll continue this way only. In Delhi, I know, if you ask me personally, I can tell you at least 5-7 such beautiful hospitals which have become absolutely paupers because of this attitude. The second is resistance, doing as little as possible. ये काम तो चल ही रहा है, जरूरत क्या है करने का. Third one is tolerance, and the fourth is acceptance, when you enthusiastically cooperate. And when you do that, that is the time you have all the possible opportunities, demand, threats, opportunities, you get exposed to everything. So this is how it is. Forcefield says that whenever you go for a change, you will have certain, you see, it starts from apathy to hostility to poor standard of trained person to retraining forces. So there are two forces, restraining forces and prompting forces. You have to look at it and make a balance and go toward that equilibrium of driving forces. So if you do that, so idea is that whenever you look forward to any disruptive innovation, you will go through this cycle of, first cycle is of fear of unknown, economic considerations and everything possible. But once the change is adopted, there are few more challenges related to the employees, workforce and leadership. There will be people who will be restraining it, there will be people who will be driving it. And we have to strike a balance between the two and take it to the next level. That is how the change can be adopted. One of the changes which I can see today is that institution has taken a lead to take the imaginative dimension forward, to prompt you and promote you that don't think whatever you have read here is enough. You will have to look for big change, big bang changes in times to come, and you should be mentally prepared to be adapting to change and continuously upgrade your knowledge to continue. I stop here. Thank you very much.